Welcome to the Medical Center Hour. I'm Marcia Day-Childress from the Center for Biomedical Ethics and Humanities. Pleased to welcome you all here to this session today, at which we're going to be considering the future of human subjects research ethics, some topics that will shape it. In our time, the advancement and refinement of clinical biomedicine have come to depend greatly on research involving human subjects. Doing so, we've evolved a system of ethical principles and practices to protect participants in research from egregious or injurious experimentation. But will this same ethical apparatus serve us adequately in the future, even in the near future, since some human investigation is already moving away from persons per se to human cells, tissues, and various other biological specimens? What does protection of human subjects mean when human investigation is undertaken at the molecular level, or with biomaterials obtained without consent, or in biorepositories using stored tissue samples from multiple generations? In such a transformed research environment, how might informed consent change, especially when patients may or may not see it as being in their best interests also to be a research subject? And as the conditions of research change, might institutional review boards' functions shift as well? And if so, how will we then assess their efficacy? Indeed, might IRBs as we know them and love them even become extinct? Our Medical Center Hour today looks to the future of human subjects research ethics, and we have with us Dr. Jerry Menikoff of the U.S. Office for Human Research Protections to address some of the thornier ethical questions that await us at the heart of human investigation in the 21st century. We welcome Dr. Menikoff, who's Director of the Office of Human Research Protections in the U.S. Department of Health and Human Services in Washington. He's previously worked at NIH, and he is also still an Associate Professor of Ophthalmology, Ethics, and Law at the University of Kansas, but he is on leave from that institution while he's had these posts in Washington. You'll find a brief biographical sketch of him in the handout. I'd like to thank the Institute for Practical Ethics in Public Life for helping us to organize this program. We also thank the IRBs here at UVA for their vigilant service to the university's research mission. And IRBs have had an opportunity to work with Dr. Menikoff during his visit. So welcome, Jerry, and we look forward to your talk.
Thank you so much, Marcia. Can everybody hear me in the back? It's a pleasure to be here. Thanks for the invitation. I'm going to touch a few topics. I was sort of asked to come up with big issues that are looming in terms of the future of human subjects research. I'm going to touch on two of them relatively briefly, and then I'm going to spend a fair amount of time on informed consent. And I look forward to a discussion afterwards. I view this as wonderful opportunities to engage interesting discussion on issues that can be controversial. I have to give you the usual disclaimer. I'm speaking on my personal behalf. Don't take me as giving you the government's viewpoint on anything. So the first topic, started out being controversial, will IRBs become extinct? And let's start out with, there was a report that came out in 1998 from the Office of Inspector General at HHS, and it was saying institutional review boards, a time for reform. And it covered a number of topics, and one particularly interesting one, this is from the executive summary. It noted that neither IRBs nor HHS devote much attention to evaluating IRB effectiveness. And it basically points out IRBs rarely looked into, are they actually accomplishing the mission that they're supposed to be accomplishing? And that HHS agencies' oversight of the IRBs really didn't do very much. And they go on to describe exactly what they're concerned about. As we conduct our inquiry, we became increasingly aware of a striking reality. IRBs have little basis for knowing how well they're accomplishing their mission of protecting human subjects. If you're familiar with this area, you'll probably hear an echo of reports you've been getting in recent years. Article after article is coming out attacking the IRB system and saying, do we really know what the benefit is of all this time and effort that everybody spends on the IRB system. And again, this isn't new. This is, within HHS, they were internally telling us a decade ago, gee, do we really know what IRBs are accomplishing? And in terms of what they were looking for, what we call for here is in accordance with what is occurring generally in the field of healthcare quality assurance. We are doing away with old requirements that focused on process rather than results. And even now, in terms of the world of IRBs, so much of what we look at is very, very process-oriented. Many people are saying we're becoming more and more process-oriented. Anybody who's familiar with probably the major way in terms of quality control in the IRB world these days is what we call accreditation. It's a private system. It's a lot like what the Joint Commission does in terms of accrediting hospitals. There's an entity called IRB that is a voluntary process that you can do to accredit your system. Highly process-oriented. You will go through lots and lots of procedures that you have and make sure you have the proper check-off boxes and that you're arguing the following thing, 10 things. Well, it's not 10, it's like thousands of things, and then you try to figure out where does this all get us. And the OIG, again, was worrying about this a decade ago, and they were noting an adequate system would require that it be subjected to regular periodic evaluations that are based on the examination of outcomes and performance. And so an interesting question is, assuming we collected all this data, because we still don't have it, assuming we really tried to figure out what the IRBs are doing, what would it show us? And in many ways, the IRB is still a black box. I sort of think about, I guess they still have them, the little sort of dark green metal box where you put a little coin in the top and this hand shoots out and pulls it into the innards, and God knows what's going to happen to it there. I'm also reminded, there's a Tom Waits song, one of his more obscure ones. He's talking about his neighbor next door, and so the name of the song, I keep repeating is, what's he building in there? I mean, he subscribes to all these strange magazines that nobody reads, and he has no children. What's he building in there? And in many ways, what are IRBs doing? We really don't know a lot about kind of what they're doing, and in particular, what outcome. So like something goes into the IRB, and does what comes out, is it all that different than what went in? And we're not actually sure. I mean, it's fascinating how little information we really have in terms of input and output. And in particular, the two main things IRBs do is they review protocols and may or may not make changes in the protocol. Well, how often is an IRB actually changing a protocol and stuff? The separate thing is, how many times is an IRB actually making a meaningful change in terms of consent forms? And of course, I'm sure a lot of you are very familiar with the complaints of many investigators saying, yes, these IRBs go and reword our grammar and correct spelling errors, and why does any of this matter? You're delaying the research, and let's add up how many millions of people's lives are lost because some new piece of knowledge is delayed because of correcting grammatical errors or spelling errors, and that sort of thing. So we really have a whole bunch of questions on this. SACHARP is the advisory committee on human research protections to the Secretary of HHS, and a very distinguished panelist, Norm Focht, who's a very distinguished pediatric ethics expert, noted recently that for multi-site studies in particular, many people are worrying about research ethics. Many people are playing a role in this, and so the question is, to what extent do we actually need IRBs anymore if everybody else is doing everything, particularly in the multi-site studies? And perhaps, and this might be an appropriate comparison or not, is it in a sense like those screeners at the airports, which we all think, why are they wasting their time? But yes, maybe they have to be there, because if they weren't there, then everybody who wants to put the bombs on the planes, etc., would be doing that. But the fact that they're not picking up any bombs or other things being smuggled in usually is precisely because they're having the preventative goal that they want. And maybe that's what the IRBs are accomplishing. Even if the input before the IRB and the output after the IRB isn't any different, the IRB has done a wonderful thing, because if it wasn't there, all these horrible things would be happening. Those investigators would be trying to push the envelope and edging their way into the sort of ethical problems we had many decades ago. So that's possible. Let me raise a few special issues for multi-site studies, which I think do raise some fascinating questions. We have the same question I raised already. To what extent do IRBs add value? And here, to what extent does multiple reviews, assuming you have a study with 50 sites, all of them in the US, the odds are good that you have quite a few IRBs reviewing that site. A number of things have been done to reduce the number of multiple IRB reviews, but we still are having that take place. And there are interesting questions, particularly in these studies, in terms of how the system works. Particularly in this scenario, probably most of these IRBs, and for any of you who are on an IRB, you could think about it in terms of how that functions. Your IRB probably suspects it cannot change the protocol in any substantial way, and it probably also suspects it can't even change it in an insubstantial way. You're sort of given this protocol, you know because it's being done in so many sites, you don't have a lot of options there. So bottom line, in terms of reviewing the ethics, it's if you conclude it's unethical, you basically turn it down for that site. And pretty much what happens then is that's all that happens. It isn't conducted in that site. It's an interesting aspect of the system. The IRBs, by and large, don't communicate a lot with each other, and it actually may be difficult. If it's a pharmaceutical company study, you hear, I don't know whether it's apocryphal or what, rumors that the companies will actually go after you. If you even talk with other IRBs on that study, they were claiming you were disclosing confidential information. Granted, you're disclosing it to somebody else who has the same confidential information, but they're saying you promised in the agreements you signed to not disclose this to anybody else, therefore it's a formal violation of your promises. They do not want the IRBs communicating with one another. If one IRB turns it down, fine and dandy, they'll find other sites to do the study, and by and large they do that. I mean, the interesting thing is if you're looking for examples where the result of IRB reviews is that multi-site studies don't get conducted, it's actually hard to find those. And that's another fascinating question. Is it that our studies are so well designed or only need a little tweaking to make them ethical? Or are bad things happening somewhere and we're just not finding out about them? It's just unclear. In terms of consent, IRBs often, in multiple sites make consent form changes, but it's unclear, again, to what extent these are impacting what happens in terms of people enrolling in the study. And you have a fascinating scientific issue. If certain sites are making such substantial consent form changes that they really are meaningful, do we have a scientific integrity issue? Because then you have certain sites that are enrolling to some extent different populations than the other sites, and that normally, in any other aspect of the study, would be deemed troubling. You're going to lose validity in the study. So one way or the other, the IRBs aren't doing anything meaningful, or if they are, some of them are doing something meaningful, that could be troubling in terms of how the study works. And of course, if the study is not appropriately designed, by definition, we traditionally conclude it was unethical, because then you have no good reason for imposing any risks on anybody. You have no goal that you would be able to reach. These are all issues that a lot of people are dealing with. OHRP has an advance notice of proposed rulemaking, fancy abbreviation there, trying to encourage institutions to use outside IRBs so we don't have so many multiple IRBs reviewing a study. We don't know to what extent what we're trying to do, which is just altering the liability rules, is really going to do much. And there's an open question of whether or not doing more would be necessary and whether doing more would be a good thing to, again, further reduce the multiple IRB reviews. The European Union, interestingly, has gone pretty far in terms of this. Each country actually has to come up with one final definitive IRB determination in each study. You can have more than one IRB reviewing study, but one way or another, you have to have laws in each EU country that comes up with one definitive determination for that country, so that that is the definitive determination that then is used in interacting with the other countries. And it's an interesting take on this problem. So that's my first topic. Let me move on to another interesting topic, specimens. What makes the use of specimens in research ethical? And the reason this is a huge and growing topic is that I think a lot of people, and I think correctly, are recognizing that use of specimens is pretty much a major element of the future of medical research. There's so much we could do in terms of genetics, genomics, in terms of gaining information about people just from their tissues, just from their DNA. There's equally not just the genetic side of it, but other pieces of information. One of the dreams again, certainly if you're interested in protecting research subjects, is dreaming of a period in which we've basically hooked up all the medical record systems in every single hospital in this country, in every doctor's office, because we have so much information there that if you churn it through supercomputers, we could probably be answering many, many medical research questions, and doing it with pretty much minimal risks to actual human beings. And maybe we're going to get to that, so the current administration is pushing that in terms of computerizing medical records. So it's certainly a wonderful thing. But there's certainly issues here in terms of what is it that allows us to do research with specimens. And there are some issues that are very much on the agenda these days. Let me go through a few of those. The initial line drawing we often do in this area is, on one side we have clinical specimens, on the other side we have specimens obtained in a research study. And there's actually a different sort of analysis you might do on either of those. They're different. Let's look at specimens obtained in clinical care. Now, interestingly, often the patient has given no consent to use that specimen in research in any way. So you might conclude, well, this is sort of problematic in terms of using it in research. But paradoxically, it works out, and I think this is correct. From an ethical viewpoint, we actually do use those specimens, and we're using them a huge amount, and we're using them more and more these days, and probably ethical qualms are less great, because we basically openly use them, saying we don't need consent, that this is one of those areas in which we'll balance harm to the subjects, and assuming we have adequate privacy protections in place, we're not harming anybody, and yet we're getting huge benefits to society without actually harming any research subjects, and therefore we as a society have said it is acceptable for us to use these specimens in many, many ways. And the same is actually true of medical data, clinical data. Many institutions, what they're doing these days are creating mirror systems of their entire medical record system, and they just strip of identifiers. And people, you know, you're good to go in terms of doing any research you want on these systems. And it's, again, virtually a total mirror image, except we got rid of the privacy constraints. So in many ways, the future of this type of research is on the clinical side. And we have legitimate ethical grounds for doing this. You know, it's interesting. Now let's compare it to specimens obtained in research. And again, normally you'd think, well, gee, these people actually consented to giving these specimens for research purposes, so it's a no-brainer that this is actually more straightforward from an ethical viewpoint. But I think, you know, many of us think it's actually far more problematic, because the way you got the specimen, the way it became part of the system, was precisely because you entered into an agreement with somebody saying, please give me the specimen for research purposes. I'm telling you the conditions under which I will use it. So you've actually made promises to this person. Unlike the person in clinical care, where again, we're using everybody's specimens, they're not having made any promises to anybody, but acknowledging we are basically co-opting them for a legitimate public purpose. Without requiring it. In the research setting, we are making a big deal of the fact that we're getting your consent on all of this stuff. And so the question is, you know, what does this mean? Is it ethical to break these promises? And let me give you some examples. Consent form will often invite subjects to choose the specific uses that you want to allow your tissue to be used for. You may often participate, I'm sure many of you have, in a clinical trial, and they'll collect some blood, you know, a piece of tissue, and then they have a checkbox list at the end saying, check off the types of uses you want this tissue to be used for. And you may check off only for cancer. One of the big issues now is, what if you strip the tissue or information you collect of identifiers? Are you still bound by those promises? A very big lawsuit out there, which has gotten a lot of attention, involves this tribe of Indians, the Havasupai tribe, and a number of the members of the tribe participated in a study on diabetes, and they gave blood, other samples. And the study took place, and then it's unclear exactly what happened, but the samples were then used for a bunch of other research purposes. It's unclear whether they stripped of identifiers or not, but let's assume they stripped of identifiers, which would get rid of privacy issues. And one of the research studies they did, which highlights the complexity in this area, what the ethical concerns are, is this tribe actually had a belief, it was part of their culture, that they sprung up from the floor of the Grand Canyon. And this was a very, very powerful belief. Well, one of these studies It just happened to be a researcher who was working on using genetics to determine where populations came from. And so he used the specimens from the diabetes study to prove that they actually immigrated from, where Russia meets Alaska. And this got members of the tribe, particularly ones who participated in the research, a little bit irritated. And there's now something like a $70 million lawsuit against parts of the U.S. system. And that's been upheld. It keeps working its way on. So these are pretty real issues in terms of, does just stripping tissue identifiers work? And in particular, when you've made specific promises. Why did we make a promise that your tissue would only be used for cancer? Assuming this wasn't in the research area, but it was a contract, would you think we'd be upholding that contract if that promise was in the agreement? And then you went ahead and said, oh, I'm going to use it for a different purpose, but I'm going to strip away identifiers first. You might ask yourself, what did the person who gave the tissue under those circumstances think I would be doing? Maybe they just didn't want it used for non-cancer purposes, and they particularly don't care whether or not I strip the identifiers or not. Another example, these are real-life examples. A consent form promises that there'll be no future commercial use of the tissue, so that nobody will try to make money off of it. So again, you strip it of identifiers, and now somebody else uses it, and they're wanting to make millions and millions of dollars off of it. Do you think this is true to the promise that was made to the people? So more and more we're raising questions in terms of, are we fulfilling the promises we make to people when we, ask them to give us tissues for research purposes? Okay, so this is sort of another aspect of the specimens issue. Is an open-ended consent to all future research using the specimen the solution to eliminate the need to recontact subjects? One of the big pushes these days is we're too narrow when we get permission. So let's get this huge open-ended consent that says, I hereby give consent for any future use possible with my tissue. And probably most people who are willing to give tissue for a lot of purposes are probably okay with doing that. So why don't we put that sort of language in there? And the interesting thing is that probably works for the great majority of studies, but it's interesting from an ethical viewpoint to accept that in some scenarios it's not going to work. And to give you a few examples, some of this is not so science fictional. Okay, you gave a tissue. A researcher is involved in reproductive issues. So they're going to take nuclei from your cells, put them in somebody's egg, and do what they have to do to kind of get the egg to start dividing and let it divide a while, and then, do some other thing with that entity, or whatever you want to call it. Early stage of a human being, and then they're going to end up killing it. We already know huge sections of our population have problems with that from an ethical viewpoint. Well, if you gave an open-ended consent to do anything with my tissue, is that okay? What if they created a stem cell line? Rebecca Skloot, who's written wonderful pieces on use of tissue, is about to finally come out with her long-awaited book on the Helo line, the woman who was the originator, like Henrietta Lack, the originator of the Helo line of cells. And how would a lot of people in the public feel if, again, you gave a specimen for research purposes, and now some researcher turns it into a cell line? And maybe it's a really useful cell line for one purpose or another. So your cells are all over the world in various labs, and all they gave in terms of consent was a general consent to all future research uses. So it sounds like there's some dividing line there, that an open-ended consent maybe is good for 99% of your average studying the stuff in the lab, but maybe there are things that we think people actually would object to, and we have to worry about sort of dividing that line. Leah's case, which I have a link there to, is a clinical issue, but it was a real case. I was actually partly involved in the consult service at the University of Chicago when it came up. A young woman from Israel, and she was from a particular religious group that allowed elders to make a lot of decisions. So she was allowing her father to make medical decisions. She had a type of cancer. She wasn't told she had the type of cancer, and the proposition was her father didn't want her to know that she had cancer or what had to be done. She would have needed a hysterectomy. And so what she was telling us, with her father being there and separately, she was okay with having a procedure done to her without knowing why it was being done and what would it be. And people thought that was very strange, and it wasn't allowed to happen. And you could read there, John Lantos writes a scenario of what happened. But it's the same scenario. The notion that can we consent to an open-ended thing without actually knowing the specifics of certain things that are actually being consented to. And that's actually a hard thing to do, because the question is, when you're consenting to something, are you thinking about the right things to think about when you're consenting to that? And when something is so open-ended, you obviously aren't thinking of everything imaginable, because you don't know what could be imaginable. And so this is actually a dilemma. It's also similar to advanced directives, issues in terms of that sort of thing. So it's fascinating from an ethical viewpoint. So let me say a little bit about gene-wide association studies called GWAS. I'm not going to say a lot, and this is very, very complicated, but this is a huge future research area. What you do basically is, we have billions of, imagine our genetics or genomics, right? We all have our chromosomes, and there are many, many letters writing our book of life, billions of them. And we've actually figured out, to understand the significant parts of somebody's book, you actually don't have to look at all billions of those. There's a way to just look at a subpart, a relatively small subpart of them, 500,000 to 1 million of what we call SNPs. And by doing that, you actually get a good take on what's going on in that person's genes. And it's a very powerful tool. And the issues that GWAS raises is, when is it acceptable for somebody to do that sort of analysis on somebody's DNA? What if there's somebody who just gave one of the general consents and just said, you can do whatever I want, you want with my tissue? Is it required that there be specific mention of genetic testing in that consent? What if that person had no idea you'd be doing genetic testing? Should there be specific mention that you're going to do this type of GWAS analysis and what that might mean in terms of how much information you might know about what might happen to the person in the future? I mean, the person might think, even if they're not nervous about somebody disclosing it inappropriately, maybe I would say, hey, if you're going to do that, and I know it now costs $500 to $1,000 to do that, the least you should do is give me the results so I could benefit from that. I'm helping society out. Why not help me out? Does there need to be specific mention of data sharing? So, number of consent issues. Let me give you one tricky example, which is highlighting the mysteriousness of all this. It has actually been very common until recently to put up aggregate data from analyzing, let's say, all these 500,000 to 1 million SNPs on people. And so what it would have is, and NIH had all of this available to anybody who wanted to look at it. You did a study. You compared 1,000 people who had macular degeneration, the back of your eye degenerates, and 1,000 people who are normal. And for each of those groups, you have the data of all of the SNPs, but on each SNP you're saying 40% of the people had this base pair, 60% had this base pair. So you're not getting any individual data on anybody. And the fascinating thing is that somebody came out with a manuscript about less than a year ago, and they basically showed that if you had that aggregate data, and you have that analysis on one person, they were able to prove to a very high degree of statistical significance, or demonstrate whether or not that person was in one of those groups, which was stunning. I mean, what I'd heard, I don't know if this is apocryphal or not, Francis Collins, who certainly knows a lot about genetics, when he heard about this paper said, no way could this guy be doing this. These people, are making it all up. And then, so NIH actually had the data pools and gave the data on 100 people to this group, and they got 99 of them right. And to show you just the example of the stunningness of this and why it isn't surprising, there's the apocryphal story of some guy who invented chess, and the ruler who he invented it for asked him, what reward do you want? He said, well, put 1 grain of rice on the first grain of the chessboard, 2 on the second, 4 on the third, et cetera, et cetera. And it works out that by the last square on the chessboard, it would be 2 to the 64, which is big enough that it would be 80 years worth of all the wheat you could grow in this country. Well, that is 64 points. We are dealing with, again, only one or the other base pair, but on 500,000 to 1 million points. It is a mind-boggling amount of information. And the fact that people in this field, including Francis Collins, didn't believe that that was enough information, that in a pool of 1,000 people, what this person was detecting actually was the fact that this person was one of those 1,000 people was tweaking the percentage in each of those data points by enough that if you look at all of them across the field, you can actually figure out whether they're in that pool. I mean, it's a mind-boggling concept, but it just is stunning in terms of what we don't know, in terms of what this all means, that we're dealing with such massive amounts of information, what might be buried there, and what risks there might be in terms of being comfortable that we're allowing people to have this done to themselves. And by and large, most of them out there right now probably don't know if GWAS analysis has been done in tissue. You enrolled in some study perhaps years ago when nobody even knew you could do this. And now it's sitting in some NIH data bank somewhere. And is this a good thing? Do we need some new protections? I don't know. Okay, so now let me move on to consent. What information should a subject be given to make consent to research alcohol? And we've obviously talked about this a long time. I love the wording in the Nuremberg Code, which I think is still compelling, that we want to enable people to make enlightened decisions about participation. We have regulations that deal with this now. They require that disclosing that a study involves research. Interestingly, we don't commonly require now a discussion of how being a research subject differs from being a patient. And I'm sure a lot of you are very familiar with that. It's not an obvious line to be drawn. And you know, should we be telling people what it means? And in many ways, a Miranda warning here, telling somebody, hey, if you enroll in this research study, the rights that you have change might be more appropriate. It's interesting, even the stupidest criminals, you know, we warn the criminals, but by and large they know that the police are not their friends. The average research subject, as we all know, probably doesn't know that the researcher has a conflict of interest and may not be pursuing your best interest when you enroll in a research study, that person has an ability to do things that are harmful to them, that are not in their best interest, which is different, of course, than the set of rights and responsibilities that exist when you're dealing with a patient in their clinical role. So you might want to, for example, disclose that a patient's well-being comes second to answering the research question, that the doctor is no longer required to do what's best for the person. Other things that you might want to disclose, what it means to be a research subject, is that things in the study may or may not be in your best interest, and spell out what those are. Some consent forms do that, many do not. These are a lot of the things that happen that aren't in your best interest necessarily. Disclosing that you won't be told about interim results. I mean, this is a fascinating thing, because theoretically, almost every research subject, certainly in clinical trials, and much of what I'm talking about relates to clinical trials, would love to know interim results. You're dying of some horrible cancer. The interim results show it's hugely likely that the arm you're in is not going to be the arm that's going to be the better one. Okay? You're going to immediately get out of that study and try something else or go to the other arm or something. Well, we, of course, don't disclose that to subjects precisely because we know they're going to flock. Well, what are we saying in the consent form? The one paragraph in there reassures them that if we learn anything that you might want to know in terms of whether or not you want to stay in the study, we will, of course, tell you that. A little tricky. Okay, now let me move from what it means to be a research subject to specific types of studies and what piece of information might be useful for you to know that often aren't being disclosed. And let me put this in terms of categories. Imagine you're somebody in a clinical trial, you have a particular medical problem, you're trying to determine the best way to treat it. So 3 pieces of information I think that are relevant to you are, what is the standard care, the treatment for your disease? What are your options in terms of non-standard care? And there I'm not talking about in a research study. Physicians have a huge ability to give new, innovative, non-standard care to patients. And thirdly, what are your options from being in a research study? And those are 3 core pieces of information. I'm going to try to spell that out in a variety of ways. So let me talk about a study that involves a new treatment and whether it gives you efficacy information. Consent form will often merely say it's uncertain if the new treatment is better than standard care. And yet if you look at a protocol, it will often give you a whole bunch of information, on the tentative information on what we know about, it's not certain information, but we know a lot about this new treatment. Shouldn't you give this information to a person? And this is just an example. There was a study done a while ago in women with metastatic breast cancer. And half of them would get chemotherapy alone, and half of them would get chemotherapy plus radiation. This was a select group of patients who had 3 or fewer positive nodes, and it was unclear at that point whether or not adding the radiation helped. And it was interesting, the consent form just had a generic statement saying we don't know which is better. If you read the protocol, it actually gives you a ton of information showing that if you have more than 3 positive nodes, it's actually hugely beneficial to get the radiation. But as you have fewer and fewer nodes, that effect reduced itself, and therefore we weren't sure about the crossing point, whether or not it wiped itself out in 3 or fewer nodes. And you'd think, knowing that might cause the woman to think differently about whether or not she wanted to be in the study. And it was interesting, New York Times in 2004 had a wonderful article, it wasn't even that long, a half a page, that discussed all this and gave you a ton of information, quoting doctors. No question that radiation would reduce the recurrence rate by 2/3, but we weren't yet sure if it increased survival. Wouldn't a woman want to know that in terms of deciding what to do? And yet it was odd. The consent form for the research study, and normally you give more information in the consent form for research, had less information than the New York Times article. So the question is something wrong going on there? Another topic, how about information about the efficacy of standard care? This is a study, it randomized people who are undergoing heart surgery. They cut open your heart, big deal, majorly possibility of bleeding. Half the people would get something called a standard fibrin sealant, which is an approved product that sort of causes clotting. It sort of clots and adds to the stability of the wound. And the other half would get an experimental fibrin sealant. And pretty much that's what the consent form told you. Now, you're undergoing major heart surgery. Maybe it's important to have a good fibrin sealant. Would you want to know what bad things might happen if your fibrin sealant isn't all that good? And this consent form told you nothing about how important is it that there's a fibrin sealant, that it's a good fibrin sealant, and how sure are we that this new fibrin sealant is going to be so good? Not that unusual. It's not uncommon that consent forms don't have that sort of stuff. Would it be different if you're enrolling in a study where standard care is very good? You have an infection. Your current antibiotics for that would cure you 99.9% of the time, versus technical term where standard care sucks. If the current antibiotic would only cure you 1% of the time, presumably you'd be a lot more willing to try some alternative antibiotic that some drug company cooked up than the first scenario where it's merely that the drug company then wants to get part of the market, the so-called Me Too drug or something. And not obvious that reading consent forms these days you're going to learn about that sort of information. Benefits information. A very common practice is that consent forms will tell you that the benefit from being in a study is uncertain. An example, a person was already on a statin drug for treating their high cholesterol, pretty standard treatment for this, and the question is, but does adding a new drug help? So the people in this study would be randomized. Half of them would get the new drug for 8 weeks, half of them would get a placebo. In terms of the benefit section, this is what it said. You may have a good response or no direct benefit. And so the question is, well, what about telling them you may have a good response? This is 8 weeks. Okay, high cholesterol is a long-term chronic disease. Probably, if you ask an expert in the field, even if this is mind-bogglingly successful, the fact that you've reduced your cholesterol a bit more for 8 weeks is like a drop in the bucket in terms of your health. So even mentioning to somebody, there's a good response. They should basically be telling, be altruistic to enroll in this study, but it's not going to do much in terms of your own health. It's going to do virtually nothing. This is an NCI gold standard. They have a template for writing consent forms. And it says, if you agree to take part in the study, there may or may not be direct medical benefit to you. Notice it doesn't tell you the likelihood of the benefit, nor the type of benefit. And notice you can actually write the consent form language without even knowing anything about the study. You've just written the benefit section for any consent form you write. Is that what people had in mind when they said you have to tell somebody about the benefits of being in a study? Okay, so let me tell you a little bit about phase 1 studies. Phase 1 studies, as no doubt most of you know, are not designed to determine anything about efficacy. It's primarily designed to see how high a dose we could give of a particular compound before we start getting unacceptable side effects. And many people would say the chance of actual benefit to people in these studies is very, very low. And subjects routinely overestimate the benefits of this, and the question is why. And there was actually a study done by NIH's Bioethics Center, and they reviewed a bunch of consent forms, and they said it didn't look like the consent forms were the problem. And the reason was that the consent forms never actually promised that you're going to benefit from being in the study. Well, the interesting question is, what did the consent forms actually say? And in fact, if you look at what they said, 94% of the forms communicated uncertainty about the benefits. And what it probably said was the sort of language we already discussed. Well, you may or may not benefit. It is uncertain whether or not you will benefit. And so the question is that acceptable if we really think that the likelihood of benefiting from a phase 1 study is very, very close to zero? Shouldn't we actually be telling people, you could not, this is not a cryptic thing. You could say in the benefit section, by the way, your likelihood of benefiting is very, very close to zero. Okay, so my final point is going into alternatives. And I think this is a huge issue in terms of why people really enroll in studies. Should getting the experimental treatment arm off study be disclosed? And let me give you an example to explain what I'm talking about. Because often it is such that the new arm of the study could be available outside of the study. This is a real study, the STAR study, a very, very important study the government conducted recently, study of tamoxifen and raloxifene. Tamoxifen was the first drug anybody discovered that actually prevented a cancer from developing. If you didn't have cancer in the first place, it would decrease your risk of actually developing breast cancer. And raloxifene was a very similar drug that people hoped would have even better effect in terms of this. Huge study, 5-year study, randomized to one or the other of these two preventive drugs. 22,000 women. Tamoxifen was already FDA approved for this. Raloxifene was actually already on the market. Millions of women were already using it for osteoporosis, but it was unclear yet whether or not it would work for preventing breast cancer. Here's the consent form. In the alternative section, it disclosed your alternatives. It said you could ask your doctor to prescribe tamoxifen instead of being in the study. Makes sense. You could actually ask your doctor to surgically remove both breasts. Again, these are women at high risk, but they didn't have breast cancer at the time. And it correctly discussed this because there was actually very good data, wonderful studies demonstrating you would usually reduce your risk of breast cancer by having, bilateral mastectomy. The one thing it didn't mention was that you might ask your doctor to give you raloxifene. It's already on the market. Nothing's preventing a doctor from prescribing. It would be so-called off-label use, perfectly legal. And in fact, there was evidence in the study. It gets complicated. The drug companies were suing each other, so they actually done surveys out there. There was evidence that a third of doctors were already giving out raloxifene. I mean, they already thought there was enough evidence that it was safe enough and could prevent this. And it's interesting. There's actually a discussion of this issue. And a fair number of people out there say, no, you shouldn't disclose this availability of getting this outside of study. And the argument is generally it's too risky an option. And this is one of the doctors in the STAR study. It's too early to use raloxifene to prevent cancer outside of a clinical trial. We don't yet know its long-term risks or benefits. Well, let's look at that. Let's follow that argument. Imagine somebody's considering enrolling in the study. The risks of getting the new therapy outside of the study would be in many cases identical to the risks of getting it in the study. I mean, most of these studies aren't doing anything fancy. They're doing standard medical tests and medical treatments, that sort of stuff. On the other hand, in terms of benefits, we already know there should be clinical equipoise, that we think there's a reasonable chance this new treatment is better than the old one, otherwise we wouldn't be studying it. So there's an honest agreement about the merits. And in terms of the benefits of a subject, there are special benefits to the subject from getting it outside of the study. This is quoting the New York Times. You could ask yourself in terms of if this makes sense to you. It is sort of common sense. Few people sign on to at least many clinical trials out of altruism. They want the experimental drugs a study provides, often regarding them in treatment, even when their safety and effectiveness have not yet been proven. So from the benefits viewpoint of the subject, they're looking at a 50-50 chance of getting the new thing, which is what they want if they enroll in the study. If they go down the road and get it from somebody else, they have a 100% chance of getting it. Isn't it, from their viewpoint, a more reasonable thing to want to get it outside of the study? And therefore, shouldn't you actually be telling them about that? I'm going to give you just the flip side of that argument. Let's accept that these doctors in a particular study are right and saying, well, this new treatment we're studying in the study is so risky that we never want to allow a doctor outside of a clinical trial to give it to anybody. It would be much too risky for that patient to actually be given it as part of clinical care. Okay, so we have a consent form about getting them in the study in which half of them are going to get this treatment. Shouldn't that consent form be saying basically, by the way, half of you are going to get this horrible treatment that's so risky at the moment that we'd certainly never let a doctor give it to you to treat you. So probably being in the study isn't good for you because you have a 50% chance ending up in this horrible arm that we think is so risky. And you could ask yourself, when's the last time you saw a consent form that said that? And therefore, if it's not saying that, aren't we effectively concluding it actually isn't that unreasonable to give this treatment outside of the study? You know, there's some degree of inconsistency in terms of this. Let me give you one more example, and then we can discuss some of this. There was a study about keyhole surgery for colon cancer. And the question was whether or not, you know, you're doing this tiny incision surgery instead of this really big long incision to take out the cancer. And the big push these days is to do the small incision stuff for lots of things, because the smaller incisions, you're healthier, you get out of the hospital sooner, et cetera, et cetera. But there was a concern in this area that due to a few anecdotal reports, they were seeing recurrence of cancer in a few people who had had this experimentally done along the tract in which the cancer was pulled out. And so the notion was it's such a small passage, you rubbed off some cancer cells or something like that. So the professional society that dealt with this area in 1994 actually said, this is so risky, none of you should actually be giving this to patients outside of a research study. Well, an interesting member of that society actually questioned his colleagues at one of their professional meetings and discovered that if they had colon cancer, only 9 to 15% of them would actually undergo this procedure. And anyhow, so a randomized study actually took place, and the interesting question is, was it reasonable for a subject to be in the study if they really wanted to do what was best for them? And you might think about how you would feel if the people in the field were generally worried that it wasn't clear that this technique would eliminate the cancer, which was otherwise highly, highly treatable in many of these patients, that this new technique, yes, it may get you out of the hospital a day or two sooner, which, by the way, they weren't even sure of yet. But on the other hand, yes, even the people in the field are so wary of it that the doctors wouldn't themselves expose themselves to that. Well, shouldn't the consent form have actually sort of said that, well, gee, there's a lot of concern about, you know, the risk of doing this study. Again, none of this is saying the study isn't important and totally ethical and valid, assuming you disclose everything. But, you know, aren't there examples of studies that are actually pretty bad for people, even in terms of randomizing to 2 arms? Yet are we being ethical in terms of telling people what they should think about? Okay, briefly to put all this together, the purpose of informed consent is to let people choose to participate or not. And maybe just listing benefits, risks, and alternatives, which is what consent forms often do, isn't enough. You have to put the information together and tell people how to use that information to make that Nuremberg Code decision about whether being in a study is good or not, good enough for you, this enlightened decision. And just sort of trick question, how many times have you seen in a consent form, here are the reasons why you should perhaps decide not to participate in the study? But if the consent form is generally designed to help you make an enlightened decision, isn't that a reasonable thing it should be telling you about? And so there's a crucial missing piece, namely going through all the risk-benefit analysis and comparing, getting standard care, getting new care outside of the study, and putting it all together. And I don't think actually that's hard to do. For example, in the breast cancer study I started out discussing at the beginning of this part of the talk, you could tell somebody that if you're somebody who really, really wants to get all the cancer out of your body, you should get the radiation. On the other hand, if you're somebody who wants to not get deforming radiation or other treatments without being very sure that it will help you, you don't have to participate in the study. And it's only when you don't have a strong feeling about either of those options that then this is an ideal study for you. Okay, and then a final point which I'm not going to talk about, so we'll leave time for discussion.
Okay, now it's your turn. We have an audience that consists of researchers, IRB members, and perhaps some research subjects. So wherever you would like to go with your comments and questions, I think Jerry Menikoff will be happy to take those. And please identify yourself when you ask your question.
I'm John Aros from the Philosophy Department. Thanks for a terrific talk. I really appreciate that. One of the interesting areas, I think, that's coming along is the problem of the scope of IRB review when it comes to issues like quality improvement. Okay? Now, there's been some discussion about the role of your office in the press involving that so-called checklist that people one day wrote about in the New Yorker and New York Times. So here's a case where, some Hopkins researchers argue that it's really going to be helpful to have a checklist of do's and don'ts in various hospitals to reduce the rate of infection. They say that it saved hundreds of lives, lots of money. OHRP apparently shut it down, arguing that everybody should have given consent. Patients, doctors, everybody. Would you care to comment on that? I know you're not speaking for OHRP.
Sure. Yeah, no, this is where, obviously, one of those touchier areas to comment on. And Sally Saptel recently did another op-ed in the New York Times raising similar issues. Firstly, there's a lot of misinformation about that study. OHRP actually never shut down anything. Hopkins voluntarily stopped certain data analysis. Nobody shut down anything in terms of people actually being allowed to use the checklist in terms of clinical care. And so just so you understand, it is disturbing to a lot of people on the regulatory side how that message does not get out. It's certainly not your fault for knowing it, but in the New York Times keeps repeating pieces that just give more information.
I just believe everything I read in the New York Times.
Absolutely. My college roommate is a New York Times reporter. It is certainly a legitimate issue that we shouldn't have the New York Times called it pointy-headed bureaucrats, that if we are not getting benefits, this is getting back to the first point I was covering, basically. Namely, if parts of our system are not adequately protecting people, are not adding any protections, we don't want to be deterring important research. On the quality improvement, quality assurance line versus being research, we have HRP has actively been working on that. It issued a series of frequently asked questions clarifying in a substantial number of areas that this is on the side that you can do the research and it's not a problem. And those are actually crafted in a way that hopefully deals with most or certainly a huge portion of the issues in this area. We actually, and had nothing to do with this, the AMA, when that scenario came out, opened up an investigation of this issue. In June, the AMA Board of Overseers, whatever it is, came up with a conclusion complimenting OHRP and closing its inquiry into this area because it thought the FAQs were so excellent, and at the moment it thinks this is all workable. And I'd be happy, I don't want to use up all the time, to go over the specifics of the other things that are occurring there, but it is a totally valid point. It is a dumb thing to sort of be imposing restrictions that deter important research without being clear that you're actually benefiting anybody. So absolutely on point.
Gene Barrett in the Department of Medicine. My question may get to be what was the topic you're going to talk about on your fourth point, but it may also relate to the first one with regard to the role of IRBs and are they accomplishing what they would like to do. And the question sort of revolves around, I think, the evaluation of the science part of clinical studies can sometimes be quite difficult. And it seems that the outcomes, if I took the example of a particular investigator, if they've gone through 20 protocols and they've never published anything about their results, does that weigh in terms of whether the 21st protocol ought to be going forward? And how would you how would you evaluate the outcomes for individual investigators?
Yeah, that's a great issue, and it does sort of get into the fourth topic I was getting at, because there's now a push in terms of, and there's a wonderful article in the New York Times not that long ago about cancer research, and how on the adult side we're not actually getting a lot of results, partly because people are not enrolling in a lot of trials, and also partly because a lot of the trials people enroll in are pretty much garbage trials that actually don't produce a good result, and that gets into the issue of are we wasting our research subject pool, basically. And the issue, and that's exactly what I was raising as an important, hugely important issue in the future, should IRBs play a more vigorous role in the future in terms of saying, look, it's some integrity to this study, it might answer a question, it's not that important a question. Right, we know from your prior studies you're not actually going to be able to complete the study, or you're not going to publish it, et cetera, et cetera. I suspect by and large it's a rare IRB that would view that as within their jurisdiction. This is a tricky thing because we're on the one hand sort of the earlier point, John's point, we don't want to sort of give more and more duties to the IRBs, but there's a legitimate issue, namely our system currently probably isn't working that well in terms of figuring out the most important research questions to be answered and devoting our resources to that. And do we need other players in that? And is the IRB one of those players, harping on the theme that if the study is unethical if it's not going to sort of do something meaningful? So I don't have the answer. I do think it is a great question, and I think more and more people are getting engaged in answering that question. And again, I'm sort of not suggesting the IRB is the way to go, but I think a lot of people are asking that. It's a hugely important question.